Let's take a look, kind of a brief overview of the spinal tract and the spinal cord, the function of the spinal cord. This is just really a brief overview. It's much more complicated, but I think it gives you a good overall view for our neuro assessments when we're looking at our patients. First, we have the cross section of the spinal cord there, and you can see that spongy material inside, and which is the gray matter, and then the white matter is on the outside. That's all part of the spinal cord. Coming out from the gray matter are our spinal nerves. This takes information and brings back information from our body, from the periphery. So this is part of the peripheral nervous system. We can have information that we touch, because it's going to come in those spinal nerves, go all the way up to the brain, cross over, and come down and have a motor response. Certain reflexes, though, when we check, like with the knee kick reflex, all that information occurs right at one level of the spinal cord, and that's why it's a reflex. It doesn't go all the way up to the top of the brain and come down. All that information exchange occurs at one level. So cross section of the spinal cord, we have white matter, internal gray matter, and spinal nerves coming out of each layer of the spinal cord, and they really work with our brain with sensory and motor information. The main motor tract is the corticospinal tract, and this is what carries information to have a motor response. So it starts up in the brain and comes down our spinal cord, and this is the one that crosses over in the medulla of the brain stem. So the right side of the brain controlling the left side of the body, left side of the brain controlling the right side of the body because of this crossover in this motor tract. The other main spinal cord tract, its sensory tract, is the spinal thalamic tract. This one brings sensory information up, things that we feel, touch, anything sensory. That information comes up to the brain, to that sensory part of the brain, so that information can be processed and you can have a motor response and back from that. The one thing about the spinal thalamic tract is the arrows pointing there. It crosses over at the level for pain and temperature. So somebody that has a spinal cord injury below that may have pain and temperature preserved on one side and lost on the other side because it's not a complete spinal cord injury. There's some preservation of the spinal cord, and they may just lose pain and temperature from one side because this pain and temperature crosses over at the level of the spinal cord. Okay, let's practice with two questions. This is going to really be based on the anatomy that we've covered so far. The first question: the brain is a complex structure and is divided into three parts: the cerebrum, the cerebellum, and the brainstem. The cerebrum is divided into two hemispheres and is further divided into 4 lobes per hemisphere. Which section of the brain controls and coordinates muscle movements? And our choices are cerebellum, cerebrum, brainstem, and midbrain. Now, we've talked a lot about the control of motor movements, but the key thing in this question and what it's asking is coordinating muscle movements. And we did talk about a specific structure in the brain that coordinates and refines our muscle movements, and that was the cerebellum. Cerebellum is that cauliflower-like structure that sits under the occipital lobe in the back of the brain, really sits on the brain stem. You can see in between the two. So the cerebellum is coordination of movements. So if we have a patient touch our finger and then touch our nose, we move our finger and they go back and forth, finding their nose and finding your finger back and forth, or standing and closing their eyes and see if they waver or lose coordination while they stand. That's all looking at the cerebellum. The cerebrum has the starting point in that motor strip, and the motor tract goes all the way down the spinal cord, but it's really not the coordination of muscle movements. We talked about the brainstem. It's going to control face muscles, it controls eye muscles, but it's not coordination of muscle movements. And the midbrain is that upper portion of the brain stem. and the motor tract does go through it, but it doesn't help coordinate the movement. The second question is, which lobe of the brain is responsible for spatial relationships? So parietal lobe, temporal lobe, occipital lobe, and frontal lobe. And remember, we said there were specific functions for each lobe, and the answer for this one is the parietal lobe. It's the blue one there in the picture, and this is really all of our sensory information that comes up to our brain or starts in our brain or needs to be processed. It's spatial relationships specifically. Temporal lobe plays a role with our hearing, short-term memory. Occipital lobe, remember, that is vision interpretation. And the frontal lobe has the motor strip in it, and it also has that prefrontal area for long-term memory, more complex thoughts, and personality in the frontal lobe. So that third cranial nerve, when we are looking at our pupil's reaction to light to see if it constricts with the light and then redilates, is really a process of that ocular motor nerve. And when you have a problem on the right side of the brain and it's compressing that nerve, it will dilate that side. So it helps localize the problem also. So if you have a right dilated pupil, you have a problem on the right side of the brain close to that nerve, and vice versa. The trigeminal nerve has 3 branches. It's the 5th cranial nerve, and it controls sensory of the face, our motor part of our our jaw, and you have somebody clench their teeth to see if all those muscles are working. The next nerve is the 7th nerve. It's the facial, so face muscles, and also the anterior 2/3 of the tongue. So when you have somebody smile and you're looking at symmetry of those muscles on both sides of the face, you're looking at the facial nerve. The 8th nerve is our auditory nerve, and it plays a role. It connects right with that temporal lobe and part of our hearing and auditory processing centers. So it really plays an important role with hearing. And what we usually do with this is take hair, and you can roll it between your fingers and see if they hear that. That's a simple way to check that nerve. It also controls some of the balance, so it's going to start working with that cerebellum. And part of our balance has got those 3 little bones in the nerve or inside the ear, and they help control balance with our cerebellum. The next nerve is the glossopharyngeal. It's the 9th nerve, and when we checking gag and the ability to swallow, that's the glossopharyngeal nerve. The next nerve is the vagus nerve, and that's really important. It really works with the autonomic nervous system and helps control internal organs. When you hear the term patient went vagal, it's usually if they've had increased intrathoracic pressure, and puts pressure on that nerve, and it lowers their heart rate and pulse, and they can pass out. The next nerve, the 11th nerve, is the hypoglossal nerve, tongue movement. So when you have patients stick out their tongue and move it side to side, you're really looking at that lower brain function down by the medulla to see if it's working. And then finally, the 12th nerve, spinal accessory nerve. It's muscles of the neck and upper back. So we'll have patients shrug their shoulders or push on our hand, move their head against our hand with resistance, and that's really looking at that 12th nerve. And again, these are very important because it gives us an idea of brainstem function. So when somebody's critically ill, it really is an important part of our neurologic assessment.